The first kind of respiratory issue we're going to discuss is pneumonia. Um, you will see pneumonia a lot in the nursing home setting. You'll see it in the hospital setting, and actually you might see it in the community depending on what kind of nursing you do. Risk factors for pneumonia: if you are either very young or very old. I shouldn't say very old, over 65. I'm getting close to that every day. If you have any immune compromised position like AIDS, HIV, if you're on chemotherapy, if you've been in the hospital, if you've aspirated anything, if you have been in a foreign country, there's all kinds of different ways that you can get pneumonia and all kinds of different ways that it can manifest. Just remember that pneumonia, no matter what, is very, very dangerous. And when they say walking pneumonia, that just means that you're very sick, but you're strong enough to compensate in other ways. Walking pneumonia can still kill you, so be very careful. Bacterial pneumonia is probably the easiest to treat because you can use antibiotics. Viral pneumonia, just like any virus, has to run its course, and so instead of treating the pneumonia, you treat the symptoms. Fungal pneumonia, um, obviously think of any kind of a inhaled fungus. I think I told you before that my mother-in-law has non-contagious tuberculosis, which is a bacteria in her lungs that basically is I shouldn't say it's a bacteria, it's a fungus in her lung that presents like bacteria, but it's not. The treatment for that is incredibly high doses of antifungals and antibiotics, and because of her age and otherwise immune compromised position, she's not even a candidate for the medication for it. So you got to be real careful with those kind of things. Aspiration pneumonia, as you can guess, is from sucking in something. If somebody chokes and food particles are sucked into the lungs. If you see this a lot in people who are on NG tubes and feeding tubes, if the feed doesn't go where it's supposed to go, it can back up in the lungs and be very, very dangerous. Ventilator-associated pneumonia happens obviously when a patient is chronically ventilated and it in some sort of care, bacteria is allowed in. And then hypostatic and chemical pneumonias have to do with chemical pneumonia obviously is if you sucked in bleach or ammonia when you're cleaning. Hypostatic means the lungs are just not moving how they're supposed to, so everything settles in them. That's a basic definition of all the different kinds of pneumonia. So how are we going to prevent it? First of all, for people who qualify, there is a vaccine, and they offer it to anyone who's over 65 years old. Using an incentive spirometer in the hospital setting, keeping the head of the bed up. I mean, there's so many things that can be done that are very easily done, not doctor order done, that will prevent pneumonia, and probably encouraging your patient, no matter what they've been diagnosed with and what they're hospitalized with, deep breathing and coughing, raising the head of the bed, getting them to exercise, using an incentive spirometer, all of those things you don't have to have an order for, and they really do help the patient. Signs and symptoms are coughing or any kind of respiratory distress. You'll hear adventitious lung sounds. Diagnostic testing, usually chest x-ray, sometimes a CT. White blood cell count. If they're trying to rule out pneumonia or a PE, they're going to do a D-dimer, those kind of things. And also to determine whether it's viral or bacterial, they will do a sputum culture, which means you get the patient to cough and you harvest the secretions and send them to the lab to be analyzed. Complications of pneumonia. Number one complication of pneumonia is death. Don't know how else to put it, but that's the extent of what can happen. Atelectasis, which means the lung collapses or the alveoli, because of the mucus, it cannot open. So imagine Imagine filling a balloon with Elmer's glue. And if you filled it with Elmer's glue, squished it around a little bit, eventually you would not be able to open that balloon. So that's what happens when a lung collapses, as they say, or atelectasis. It's the alveoli just sucking together because of the mucus, and then no oxygen exchange can happen. Another issue is sepsis, which becomes a full body illness, meningitis, especially in young people with pneumonia, pericarditis, which means an infection surrounding the heart, as well as endocarditis. So nursing diagnosis. You guys can name them. We're going to be working on some in class, but we really want to look at, sorry, I switched the slide early, impaired gas exchange, ineffective airway clearance, activity intolerance. That is a big one because they just can't care for themselves. So again, we'll go over more of those in class, but try to always, when you're looking at a disease process, come up with 3 or 4 nursing diagnoses and let those nursing diagnoses direct your interventions. Nursing diagnoses aren't just to name the nursing diagnosis, it's to help you choose what should be done for these patients. So therapeutic measures for these patients would be, first of all, antibiotics, oxygen, bronchial dilators, nebulizer treatments, expectorants, rest, fluids. We're not going to give them cough suppressants because we want the junk in their lungs to come out. And we want that thickness and that mucus to become fluid. So we will give them a lot of fluids as long as they can tolerate it. So that's pretty much the basics of pneumonia. The next disease process we're going to talk about is tuberculosis, and it's bacterium, Mycobacterium tuberculosis. And again, there's contagious and there's non-contagious. This disease can lay dormant in a person for years and years and years, if not their whole life. Usually people that actually have the signs and symptoms of tuberculosis have other immune issues. Tuberculosis was pretty, I don't want to say it was eradicated because it wasn't eradicated, but there wasn't a lot of it until HIV / AIDS came on the scene again because those patients are so sick and have no way to fight infection. So tuberculosis rapidly sets in. As you know, we do a PPD, and we all have to have them because God only knows what we're exposed to. Once you have a positive PPD test, they won't do the skin test anymore. After that, you have to have a chest x-ray. And again, if someone has a positive PPD, that does not mean they have active tuberculosis. It just means at some point in their life they have been exposed. A lot of people who have traveled to foreign countries, specifically countries like Africa, will be positive in the PPD testing. Risk factors: poor living conditions, drug abuse, elderly, any immunocompromised position, so HIV, AIDS, cancer, anything like that. So how do we prevent it? Live in a clean and ventilated living condition. If you know there's a TB patient, they are isolated from other patients and they're put in a negative pressure room. And what negative pressure room means is that the air in that room is specific to that room, and it's basically sucked out of the building separately. It doesn't come wafting into the halls to infect the other residents. If you are caring for a person with tuberculosis, you want to make sure you have an N95 respiratory mask and you're gowned and gloved and all that good stuff. People with tuberculosis, they'll have a chronic productive cough. They're sick. They have a lot of night sweats. You got to be careful with this, and women in their 50s because they have a lot of night sweats too. So you have to determine what they're from and not ignore the night sweats as menopausal. So it's kind of a double-edged sword there. They'll be very sick. Chest pain, fatigue, poor appetite, weight loss, low-grade fever. Again, very sick people. Treatment is this drug regimen right here. And if you look up all these drugs, you're going to realize that they are grossly toxic. as you know, any medication, every medication, amoxicillin, whatever, is chemotherapy. So chemotherapy works to either stop cells from reproducing or cut off a cell's blood supply. And whenever you give any kind of chemotherapy, whether it's antibiotics, um, uh, cancer drugs, there's risks involved, and the risks for TB drugs are high. These drugs are tough, and they do a lot of damage to the body. So the benefits always have to outweigh the risks, and you need to know the side effects, especially of the first-line drugs, because they are wicked, the things that they do. So look up these drugs and know them and their side effects. And you might want to look up these. Now, I'm not asking you to memorize these. I'm asking you to look them up and know their adverse effects because they're prevalent. You might see one of these drugs on my test, but you will definitely see something to do with TB drugs probably on the boards because they are wickedly horrible drugs, but they save lives. So when a patient comes to you with TB, let's run through the nursing process. Assessment. What's the patient going to look like? Head to toe assessment. Give me some nursing diagnoses. Again, we're going to do this in class, but on your own, come up with 4 or 5. And remember, the nursing diagnosis is there to direct your care. It is not the answer. It's just the direction for your plan and implementation. Here is a good website that goes over tuberculosis and what do you do when you have a patient who's been exposed or has active TB. So this is all I'm going to cover in this video, and on the next video we're going to talk about influenza, obstructive disorders, and so on. So thank you for listening to video 2, and video 3 will be on in a minute.